All right. So without further ado, we're going to introduce Dr. Collichio, research to practice immune checkpoint related adverse events. And so I want to say welcome, Dr. Collichio.
Hi, Tim.
Thank you so much for being
I'm
here.
staring so much at the picture down there and all those nice-looking people.
Oh, yeah. Well, we have an amazing team that puts all this together, and we're very thankful for that. I'm thankful to have you here today. So let's see. We've got our presenter information, and anyone's welcome to read that. But we have some top highlights. So you are an MD at the UNC Lineberger Comprehensive Cancer Center, and a member and a professor of medicine at UNC Chapel Hill in the Division of Hematology and Oncology. You've held several leadership positions in medical education in the U.S., part of the complex skin cancer program at UNC, and 3 amazing grandchildren, James Neal, 3, Tony Collichio, 2, and Lila Neal, 9 months. And married to Bob, and have been happily married since 1986, and they still enjoy riding bikes together. And if you have toddlers, you want to tell us about this one?
Yes. So, for many years, I've been making things out of junk.
Uh-huh.
Previously CDs, but lately Tony is fascinated with applesauce and yogurt packs. And if you take the top, it looks like a propeller. So all you have to do is attach that to the cork bottle of your wine, and you do need a little pin and a little hot glue. So don't do this with your kids unless you're careful with hot glues and pins, and a little string, and you have a little helicopter instead of throwing the trash away.
That is very cool. Thank you so much.
It's pretty fun.
Well, let's see. I mentioned poll everywhere, so today we're going to be asking immune checkpoints engage when proteins on the surface of immune cells called T cells recognize and bind to partner proteins on other cells, such as tumor cells. So this is a true, false. Everything's anonymous. There's no risk here, so take a chance. While you're doing that, I'll flash up our ACCME disclosure, our ANCC disclosure. There they are. You've seen them. And let's give them 10 or 15 seconds to go ahead and respond. Again, immune checkpoints engage when proteins on the surface of immune cells called T cells recognize and bind to partner proteins on other cells, such as some tumor cells. Trending pretty heavily on the true.
Yeah, I think they got it all right.
They got it. Okay. All right. So without further ado, immune checkpoint-related adverse effects or events, and I'll turn it over to you.
Okay.
Thank you, Dr. Collichio.
Okay. Hi, everyone. Just being careful with our masks. So this is my second or maybe third time giving y'all this lecture, and there is a lot to cover. It is part of our everyday lives in oncology now to use these medications. And so knowing the side effects is so critical to taking good care of our patients. We're going to go over the mechanism briefly. And as in previous years, I'm going to organize it by the events that we think about, the events that we don't think about, but we need to, even rarer events, and some of the effects of combining treatment, and a concept that we now call delayed related events. We also want to talk about what can happen if you re-challenge these people with these medicines, and if there's time, I have got a pretty good case at the end. So I've organized my thoughts about systemic therapy for cancer in these buckets. And as time goes along, it seems that there's another bucket all the time. Under chemotherapy, I added antibody drug conjugates because I didn't want to make them a new bucket. But, those are pretty safe medications. Hormone therapy, target therapy, biologics, and immune therapy. And I do distinguish biologics differently from immune therapy. I think of biologics as a medication that can bind to cancer cells, such as a CD20 ligand, and I think of that differently than immune therapy, which is medicine that uses your body's own immune system to improve outcome. And we have to be careful because immune therapy is a much bigger term than we thought of several years ago. We have the immune checkpoint inhibitors, which we're going to focus on today. Interleukin-2 was the only treatment for melanoma in 1985. It's going to come back in vogue as a new treatment indication along with TIL cells. Interferon's been out for years. CAR T and BITE is part of the immunotherapy program, and a lot of us will consider oncolytic viral therapy as part of immune therapy. So when I talk today about immune checkpoints, we're really focusing on that side effect because there's many other immune therapies that have different side effects. And this was the revolution in cancer, right? And the reason why I'm giving this talk is because as a skin cancer oncologist, we've been using these drugs since 2008, but they didn't really come into vogue until 2016. So I've had a lot of experience with them. And here's the cartoon that you've seen before showing the mechanism of the immune checkpoint. There is the immune checkpoint that is away from the cancer. It could be in the liver, it could be in the blood, it could be in the spleen. And basically it shows that the antigen-presenting cell, dendritic cell, is engaged with the T cell. And when that happens, they initially talk, but then they turn off through the CTLA4. So that turns the immune system off. And the medication that has been devised to turn the immune system back on, in this country is most often ipilimumab. It's a CTLA4 inhibitor, so it's an off to the off. And so you get a whole bunch of T cells that are now stimulated to recognize cancer. At the tumor, it's a similar process that a T cell is engaged with the tumor cell, and through the connection of PD-1 and PD-L1 that eventually turns off. But the antibodies that were devised to PD-1 and PD-L1 turn the off, and so you get the immune system back on, so you get a bunch of T cells engaged at the tumor. So think about white blood cells and inflammation as we go forward. Now, the immune therapy medications don't work for everybody, and they don't work for every cancer. There's 4 different boxes that you can think of in this classic graph from Dr. Wargo in 2018. Cancers have genes, and some of these genes allow them to be more recognized by immune checkpoint inhibitors. Cancers have a microenvironment. The example I always give is that pancreatic cancer is full of scar tissue, so it's harder for immune checkpoints to get into pancreatic cancer. We know now that the colon is critical in how our immune system works, and so people who have healthy bacteria in their colon may respond better to immune checkpoint inhibitors. And the systemic immunity is really important, and that's where sort of my grab bag term of, what's happening with the physiology of the patient, other blood cells that are involved, etc. And last but not least, I put the family, friends, the nurse, the doctor in the middle. You can't get all this to happen unless, there is a lot of support around the patient. So the side effects are hard to describe to patients because the side effects can be any part of the body. We're going to go through them. And this cartoon has been shown for 9 years. It's just, any part of the body can be affected by these medicines because of the stimulation of white blood cells. And we didn't get into it, but there can be antibody stimulation too. So let's go through the events that we think about, because this just needs to be part of your vocabulary every day. It'll make taking care of your patients with cancer who are on immune checkpoint inhibitors so much easier if you could think about these events every day. So the first case is our 65-year-old gentleman who's on pembrolizumab. He's coming for his 2nd cycle of treatment. He feels great. He has a little rash. It shows up as patches in his arms and legs. And so on this picture, you could see these pink patches in the arm. The labs are normal, and can you give him his treatment today? So, have you stimulated too many white blood cells and so it might not be safe, or can you do it? So in order to know whether or not you can give your patients their treatment, there's 2 tools that you need. The first one is you should download to your phone the CTCAE document. I'll try to find it later so I can show it to you. But just download it, and when you update your phones as required every now and then, it'll get updated. And on the website, you can actually type in the side effect rash, and it will tell you if the rash is a grade 1, 2, 3, 4, or 5. There's no 4 or 5 rash, but it'll tell you a grade. And it could be for any side effect. You can do it for shortness of breath, for diarrhea, you name it. Any side effect that the patients are getting from their cancer treatment is on this website. The second thing you need to have facility with is this document, the NCCN guidelines that are constantly updated. The management of immune-related adverse events is in the supportive care portion of the website, and it was developed by ASCO and NCCN working together. It's really a wonderful document. So if we go to that part of NCCN and we look at rash, if we go to the CTACE and we look at rash, we'll see that our patient actually has a grade 1 rash. His rash is occupying less than 10% of his body, so it's grade 1. And then if you go to the NCCN website, you'll see for grade 1, you can continue his treatment. So it's super easy. Now, of course, you won't want to do that every time you see a patient who has a side effect. You're just going to kind of remember these common things, and they'll just be part of your everyday life. Next case. Now we have a 28-year-old man. He's on ipilimumab. Please notice the dose on this case. It's really important. It's 3 milligrams per kilogram. And nivolumab, 1 milligram per kilogram. He gets it every 3 weeks for melanoma to the lung. When he presents to the clinic before the start of the second cycle, he reports he has 3 loose stools for the past 2 days. There's no associated abdominal pain, bleeding in the stool, or fever, and on exam he appears well and vitals are normal. The reason why I want you guys to focus on that dose is because that dose is most often used in melanoma patients. And a lot of times if you're treating kidney cancer or lung cancer, that dose will be flipped to 1 mg per kg for IPI and 3 mg per kg for nivolumab. And even with some of the melanoma patients, the dose is flipped. On this dose, the side effects are much, the likelihood of getting side effects is much higher. It's up to 60%. Grade 3 and grade 4. So let's think about this guy. Can we give him treatment? He's got 3 loose stools. Can we do it? And here's the grades that are listed on that app. And with 3 loose stools, it's only grade 1. So can we do it? And let me just see what you all think. Can you give him ipilimumab with grade 1? You know you can, and you're right. And I did. I gave him the treatment. This was many years ago, and he called 2 days later, and now he has 7 watery bowel movements. So I always show this example because I always feel bad that I gave it to him. And he's told to come back to clinic for care, and on the drive over, he got a fever and chills. So he's got a little bit of fever, 101. His heart rate's high. He's flushed. He's got a bit of abdominal pain. He's got a little bit of left shift in his labs, but otherwise he's okay. We admitted this patient, and I want you guys to think about what are you doing when your patients come in with ipilimumab and they've got some pretty significant diarrhea. A lot of things should be going through your head. Please think about the inflammation in their gut, and think about that they could be having other causes of their diarrhea, such as C. diff, infection. You get stool calprotectin, maybe a lactoferrin level. That'll tell you how much white blood cells are in their stool. Think seriously about getting CAT scans because these patients can perforate, and it can be very hard to find on physical exam. GI consult can or cannot be done. Sometimes the cases are so obvious that they're due to ipilimumab that we don't need to consult with GI, but if there's a lower grade, I will often ask GI for help. Quantiferon Gold is to find out if these patients have ever been exposed to TB, but you do not need to hold off on therapy while waiting. I do get a Quantiferon Gold just so I know. And then hepatitis serology pretty much comes out as part of everyone's treatment plan to begin with, but do make sure you check for Hep A, B, C. And then pan-endocrine labs, we're going to get into that. Make sure you check their thyroid function. And if it's morning, you can get the cortisol level. So all that should be running through your head, but the main thing you need to think about is the colitis. This is how people can die, and they did. when we first started using ipilimumab many years ago, and I guess they still could. But, if you treat this early on, you recognize that they should not have a bowel perforation from this any longer. The picture shows the colonoscopy, and you can see some areas of red inflammation on the colonoscopy, and on a biopsy you have these crypts, which are full of white blood cells, which are the T cells that have been stimulated. And so the patients have a clinical condition that's almost exactly like Crohn's colitis. And so how do you manage these people? Again, go to the NCCN and it will tell you what to do. But basically they need to be made NPO. You slowly advance their diet. You give them high-dose IV steroids with Solumedrol. And here's a key thing. If they don't improve after 1 to 2 days, you treat them with further immunosuppressive drugs besides steroids. You give them either infliximab or vedolizumab. Our inpatient formulary carries infliximab, but vedolizumab is safer, and we'll get into that. So key concept number 3, and this is for just about all the immune-related adverse events that are grade 3 or 4, steroids need to work quickly. And if they don't work within the first couple of days, then move on and give these patients more immunosuppressive stuff, or they'll get into trouble. I wish I could see you all, because then I could see how it's going so far, but I'm pretending. Case 3, this is a 48-year-old who has COPD, and she was diagnosed with metastatic adenocarcinoma of the lung. She has no targetable mutations. Her PD-L1 is very high for lung cancer, greater than 50%. And per standard of care, she's treated with single-agent atezolizumab, which is a PD-L1 inhibitor. 1 week after the second cycle, she comes to the emergency department, and this is a cross-section of her CT scan. She's hypoxic, 85% O2 sat. Blood pressure is 135/80. She's got a little fever. So things should be going through your head when you have a patient coming to the emergency department with hypoxia on checkpoint inhibitors. What are you thinking about? And yes, you are thinking about, let's see, the poll shows. You guys are too good. Yeah, okay. We got some votes for COVID. Yep, good. Yeah. And I think you should think about both COVID and pneumonitis. And in typical form nowadays, we're doing the respiratory viral panel for these patients right away. The sensitivity is high. So you'll know if the patients have COVID or other respiratory viruses, as well as pneumonitis. Every time I look this up for this talk, I'm amazed that the incidence is not higher than this. And this is actually based on the most recent reference I could find was 2016. But I really think that pneumonitis is much higher. Grade 3 pneumonitis is higher than this. Lower grades are fairly high. In melanoma, it's 1.6%, and in lung cancer patients, it's 4%. We know that COPD and smoking are risk factors for developing pneumonitis. Onset is variable, 2 to 12 months. The symptoms are cough, shortness of breath, cyanosis, and fatigue. And as I said, you do your differential diagnosis. Lymphocytic spread is part of the differential diagnosis. It would be very unusual for a lung cancer patient this early on in his course to get lymphocytic spread. So I agree with all the poll everywhere that it's infection and or pneumonitis. If you don't diagnose this soon, they can get irreversible lung disease. And this is how we would manage the patient. Just make sure you know where to find this in your NCCN. These patients will go on high-dose steroids, and they will also go to further immunosuppression if the steroids are not effective in a couple days. Case 4. Here's our 65-year-old on ipi/nivo for metastatic melanoma to the liver. He has 2 treatments, presents for an unscheduled visit with upper abdominal pain and bloating. He's got a little bit of white count. AST's high, ALT's high. Alk Phos is not that bad. Billy's not high. Protein, albumin are okay. At the top CAT scan, that's his baseline CT. The bottom is the CT that we have right now. So what is the most likely diagnosis for this patient? Is it his cancer getting worse? Does he have pseudoprogression? Does he have immune-mediated liver toxicity? Does he have reactivation of Hep B? This case, actually the patient did have progression of his cancer, but we didn't know in the beginning what was going on, and we thought it was immune-related adverse event. And this is what you just need to lean on when you don't know, is make sure you treat your patients with transaminitis, with steroids on that algorithm. Also tell them to stop drinking alcohol while their liver is quite inflamed. Hold other liver toxins. The classic one are the statins for hypercholesterolemia. This patient did have his bilirubin checked, but check INR too. Check for Hep A, B, and C, and consider other viral infections if the patient's immunocompromised. You do a Doppler study if the direct bili or the Alk Phos are high to look for clot. And this is how you take care of this patient. Oh, I guess we got it backwards. So I already gave you the answer. I'm going to go further on. And the treatment is the steroids. And here's a pearl for today. Don't give these people infliximab, because infliximab causes hepatotoxicity. Going further from steroids is mycophenolate or azathioprine. I usually get liver involved if the patients aren't responding well to steroids. Okay. Case 5, and we're still within the cases that you should be thinking about. This is a patient with kidney cancer, also on dual checkpoint ipi/nivo. He presents with headache and peripheral vision loss. Before he started his treatment, he had a normal brain MRI. His exam shows he's hypertensive. Otherwise, he's pretty much okay. And that's his brain MRI. And look for the pituitary gland on this brain MRI. And there it is. And you shouldn't see them very easily. So this pituitary gland is very boggy. What's the diagnosis? So this patient has hypophysitis, which is one of the AEs that you get more often with a CTLA-4 inhibitor than with a PD-L1 or PD-1 inhibitor. This comes a little bit later than the other side effects that we've just gone over. They present exactly like this patient did, with headache, fatigue. They can have muscle weakness and a visual field cut. They have often hyponatremia. We'll have our patients get a morning cortisol level. Oftentimes, if they have a little headache, they have to get it done before 10 a.m. Otherwise, the lab is not accurate. And then further workup would be to check the ACTH. These patients will have a low TSH and a low T4 because the pituitary gland is not working. And they can develop adrenal crisis, which is why we had them go to Amazon and get a bracelet that they have adrenal insufficiency. You don't treat these people with steroids. You treat these people with hormone replacement. All right, case 6, still in the common ones. This is a 64-year-old man. He's on Pembro for lung cancer. He's a jogger, but lately he can't run because he's kind of shaky. His exam is normal. You send him up to the infusion, and while waiting for the chair, the thyroid labs come back. Oh, here's his labs. His TSH is 0.15, which is really low, and the free T4, I'm telling you, this is really high. What's the diagnosis for this patient? Well, low TSH, high free T4. Bingo, hyperthyroidism. And And it's not hypophysitis because if it was hypophysitis, the free T4 would be low too, because that's a total blockage of that system. So when you see them when you see this relationship, it's hyperthyroidism. And it kind of freaks me out because you can't replace the thyroid gland when patients are hyperthyroid. So you have to ask yourself clinically, how is the patient doing? And in some of our older people, we worry a bit more that they might develop some cardiac complications with hyperthyroidism. So you beta block them if they are symptomatic. And if the free T4 is really high, like this patient, I get an endocrine consult. I think they should follow along with me. Graves' disease is really, really rare from from immune checkpoint inhibitors. So if the condition persists for more than, I think it's 30 days now, then you can check for anti-thyroid peroxidase antibodies and antithyroglobulin antibodies. I think if you're getting into Graves' disease, then you're going to get an endocrine consult. Hypothyroidism, which is at the top part of this slide, is just the opposite. Your TSH is high, free T4 is low. Okay, still in the things we need to be thinking about are all the room conditions. There's so many. Inflammatory arthritis, myositis, PMR, vasculitis. I've definitely developed a more comfort level with getting patients started on treatment for the rheumatologic complications. But I often will consult our rheumatologist who readily sees them with me, and we can get into some of the fancier disease-modifying agents for these conditions. And nephritis, my goodness, it's probably out there more than we see. The UA is the way to diagnose these things because you look for white cells in the urine. A little bump in creatinine can be seen. It's really hard to diagnose because the gold standard is to biopsy the kidney, and we don't like biopsying kidneys. Okay, so those were the common things. There's quite a lot. And now I'm going to go through a couple of common things, and we forget about them, but they're really important to patients. So here we go. I had a really hard time finding a picture of a dry mouth, and so this is probably a bit of an exaggeration of what you'll see. But, you do see this. So in case 7, patient with lung cancer on carbo, pemetrexate, and pembrolizumab presents for her 3rd cycle of treatment and complains of pain on the left side of her mouth. An examination of her mouth, the mucosa is pink. There's no abnormal lesions, but her lips are dry. This is obviously drier than the actual case. She has no swollen glands, and there's fullness over her left parotid gland. So what is the diagnosis for this patient? Does she have mucositis? Does she have thrush? Does she have metastasis to her parotid gland, or does she have Sicca syndrome? And right, so she actually has Sicca syndrome, although the antibodies for Sicca syndrome would not be positive. For mucositis, you would see red areas in the mucosa, so she doesn't have that. And for thrush, you'd see the classic white spots. So these patients on immune checkpoint inhibitors get very dry mouths. They can get some fullness over their parotid gland because that's where the inflammation is in the parotid. They don't make as much saliva. It's hard to treat. The guidelines in NCCN give us some guidelines, but it's hard to treat. The main thing we have found to be helpful are throat lozenges, just to kind of keep moisture up there. Sugarless gum or candy. We have tried solutions of steroids, but it's not very helpful. This is another really common symptom, and it's part of my informed consent for my patients who may not necessarily need immune checkpoint inhibitors, some of the people with getting adjuvant care. So if a patient has arthritis going into this, or maybe they're a young person who had a skiing accident, had a ACL injury, they need to know that by taking these medications, their joints could hurt more than they otherwise would hurt. And this is different than the rheumatologic inflammation that I've talked to you about. It's kind of just an exacerbation of their underlying orthopedics. or the underlying OA or damaged joints. And we work closely with orthopedics for these patients. They can get injections with steroids, and that will help them comfortably get through their care. And neurotoxicity is common, and we've seen all of it. Neurotoxicity on the face, neurotoxicity on the tongue, neurotoxicity that's peripheral, anything, anytime, anyone, hard to treat. If it's low grade, you can treat through it. Okay. Now I'm going to slow down a little bit because I can, because it's only 12:30. And I want you to know these rare but very serious side effects that can happen to the other parts of the body from immune checkpoint inhibitors, the heart, the nervous system, and I think most important for today is pancreas. So for the heart, these are the main things patients can get. They can get myocarditis, pericardial disease, and arrhythmia. I thought, part of the COVID pandemic for me was interesting because the myocarditis that I had seen my patients get from immune checkpoint inhibitors very similar to the myocarditis I was seeing from COVID. So it's something to think about when the patients come in with chest pain on immune checkpoint inhibitors and unusual EKG changes. These severe neurologic toxicities, if you see them, they'll blow you away because it's hard. Encephalopathy can happen. It can be very subtle. One of our patients was one of the first patients to take pembrolizumab before it had a name. It was a number. And she took it for her stage 4 disease over 10 years. So she took it for a few years and then took a break, then took it for a few years, then took a break, then took it for a few years. And each time she took her pembrolizumab, it helped her cancer. But towards the end of her life, she was getting confused. And on spinal tap, we found some white cells. So she had some encephalopathy from the treatment. Meningitis would be a much more obvious diagnosis. People come in with a rip-roaring headache and are found to have T cells on their spinal tap. Myasthenia gravis, I can't remember if I included the case this year or left it out for time, but it's pretty dramatic when it happens, and you have to engage the help of your neurologist. Guillain-Barré, I think I might have seen it once, but we weren't for sure. And transverse myelitis, I recently read a report of that happening during the treatment with a LAG-3 inhibitor. So here's a case that I highlight for you today because I don't want you to forget to tell patients about this when you're doing informed consent. So we have a 54-year-old woman who has triple negative breast cancer. Her combined score is greater than 10. And because of that score greater than 10, her standard of care for stage 4 triple negative breast cancer is paclitaxel and pembrolizumab. So she's treated with that for 2 months, and she comes to ED with confusion. Her blood sugar was 350. It's not that high, but her bicarb was a little bit low, and CT head was negative, tox screen and alcohol were negative, and on a ABG, she's acidotic with a pH of 7.29. So what does this lady have with a bit of elevated blood sugar and acidosis? Does she have sepsis? Does she have DKA? Or does she have aldehyde toxicity? I always teach the residents, everybody has sepsis until proven otherwise when they come into the hospital, so just don't miss that. But this lady has type 1 diabetes, and she's in DKA. And this is what happens to these people. They get a dramatic presentation of their diabetes when it happens. And it's not as rare as you think. It's 3 out of 1,000 people. And you treat the DKA per your institutional standard. You can check for C-peptide. If it's low, it's consistent with type 1 diabetes. You can check the anti-GAD and HLA-DR, but it's like a lot of other immune checkpoint inhibitor side effects. It can be confusing. They're not. You often don't find the anti-GAD. This is usually a permanent problem, and because it's due to destruction of the beta cells, these patients need to be treated with insulin. I'll put the references there for you. Okay. I'm on another key concept, and this is number 5, and that is if you combined your combined therapy, you're going to have more side effects. So the cartoon shows you several different combinations. I've got the dual checkpoint inhibitors. We talked about that a lot today. In the cases I've given you, Ipi-Nivo being probably the most common dual checkpoint inhibitors that are out there. Opdualag, which is Nivo-Rela, is another dual checkpoint that's commercially available. You can also combine your immune checkpoint inhibitor with chemotherapy. You can combine it with target therapy, but not so often. You can combine it with oncolytic viruses. If you combine immune checkpoint inhibitors with radiation, so far I have not seen an increase in toxicity. Sometimes we're a little bit about an increase in burn, depending on which part of the body is being radiated. But generally, that's very safe, and that's why I drew the blue X over that part. Okay, so, when this stuff came out, everybody was happy because it's not chemo. Don't be happy. I wish cancer didn't happen to anybody. The point of this slide is to remind you all that when you give someone chemotherapy, you've got predictable side effects. You know when their counts are going to drop. You know when their counts are going to come back up. You know that their hair is going to come out or not. So it's pretty predictable. But when you give immune checkpoint inhibitors, the side effects are unpredictable. The timing of the side effects is unpredictable. And so that has to be part of your informed consent, too, to the patients. They just need to know that we don't know until we start. And I can't give a talk without discussing herpes, because that's what I do in the clinic. I treat a lot of people with this compound called telemagene leheparevac, which was made out of herpes simplex 1 virus. It's a good reminder to us what viruses look like. In this case, we've got a virus that is has the protein around the edge and then the genetic material inside. And what was done to make telemagene leheparevac was to genetically modify this so that the drug does not cause any infection in the human, but it infects the cancer. And GM-CSF is part of the medicine, so the immune system is augmented by giving this drug. And it's only approved for melanoma, but it's still fun to talk about. The way we do it is we inject it actually into the cancer itself. And when we inject it into the cancer, then it will cause the cancer to lyse. And as the proteins are released into this microenvironment, the GM-CSF causes dendritic cells, shown in this aqua color, to come into the area, and then the cancer dies. And there can be some systemic outcome from this medicine, but not very much. Most of the effect of telemagene leheparevac is on the local tumors themselves. But we have done some research where we combined TVEC, which is the nickname, with checkpoint inhibitors. And so because this is a talk on immune-related adverse events, TVEC, being that it's a virus, causes flu-like symptoms, and the checkpoint inhibitors cause their side effects, but they're not additive. So we don't see more pneumonitis, we don't see more colitis. We see both side effects, not additive. Okay. So now we're on to this concept that I've known about for years, but didn't really see too much in the literature, so it's kind of just starting. And this key concept number 6 is called the delayed immune-related adverse events, or DIAR. So this is an 82-year-old patient. She's treated with an oncolytic virus and cemiplimab. Cemiplimab is a PD-1 inhibitor, approved for many different disease types, but in her case, it was for her squamous cell carcinoma of the scalp. And she stayed on the treatment. These are all made-up cases, by the way. And 3 years into it, was tired, and her liver function tests were abnormal. But 3 years into this, she barely drinks anything. Takes a little bit of Tylenol, so not much liver toxic stuff in her body. And her dire side effect was delayed toxicity to her liver. So cemiplimab was stopped, and she got better. We did not have to treat this patient with steroids. She got better. So as I dug into the dire side effect for today's talk, I found multiple case reports, mainly for endocrine, skin, and lung, but there was some liver. I found them multiple disease types, mainly lung cancer, melanoma, and breast cancer. So do keep that in mind. Just because your patient has been fine on their immune checkpoint inhibitors doesn't mean they'll stay fine. And this was a more detailed article by Dr. Owen et al. In Annals in 2021, showing that any part of the body, which is left graph on the bottom, could have a dire side effect, and that the timing could be late as well. So later on, if you want to study this more, you can go back to this slide. And then some of these actually occurred months after stopping, and so I think that's important, especially when patients come into the hospital with, say, pneumonia, and they had been on pembrolizumab many, many months ago. Think about that. Are they more inflamed than your average human because they've had an immune checkpoint inhibitor in the past? Okay, so one of the questions I get asked all the time is, my patient has RA, so can my patient with RA get an immune checkpoint inhibitor for her cancer? So I found this happy lady in the PowerPoint photos. That's where all these come from. And she has underlying RA. And what you need to know is that when patients have an underlying autoimmune disease and you treat them with immune checkpoint inhibitor, in general, their underlying disease will get worse. 1/3 of the time they'll have an increase of their autoimmunity. And in general, they're going to be at increased risk for a grade 3 or 4 IRAE. So it's 2/3 of these patients can get sicker from these drugs because they carry this underlying condition. So you have to weigh risk and benefit, and if you've got a patient with stage 4 disease who's going to benefit greatly, then, talk to them about it and see what they want to do. Okay. As you get more and more familiar with these drugs, you get more and more familiar about, can you re-challenge? This would have taken several more slides and minutes to go over with you guys, but I'm happy to tell you that the NCCN guidelines has a nice long section now on re-challenging, and a very nice chart that goes over each organ toxicity and whether re-challenge can be done or not. Here's a few general points. If a patient was treated with a dual immune checkpoint inhibitor, such as Ipi/Nivo, you can usually resume the PD-1 part. The classic thing is with Ipi/Nivo and they get the colitis, you drop out the Ipi and you can continue the Nivo once they get better. They have to be off of their prednisone. The endocrinopathies, in general, it's safe to resume because you're replacing the hormone that was damaged when the thyroid or the pituitary gland or adrenal gland was damaged, so you replace. And then for the eyes, you continue the steroid eye drops. You can resume your immune checkpoint inhibitors when the toxicity goes back down to grade 1. For these severe ones I talked to you about today, the heart, the brain, no, I'm going to be very, very, very risky to go back on an immune checkpoint inhibitor if they've had toxicity to their heart or their brain. Here's our eighth key concept. This is a team approach. So proud to know Dr. Ishishawar, who leads the multidisciplinary team at UNC. Every year, she and her team update this document. This is sort of a more detailed look at some of these things. It helps me when I look at NCCN, and I'll also look at here, and it kind of shows you what is the standard operating procedure at UNC when some of these things happen. And then there's people that have been designated amongst the disease sites as the to-go person for most of the areas that we look at. So for GI, for nephro, etc., there is often a designated leader for that. So let's close, and then we have lots of time for questions. So we talked about a lot of key concepts today, and I will have time to show you the application that you need to have on your phone. That's your CTCAE application. I'll look for it right now. Looks like that, okay? And it's free. So get used to using that for grading. And then get used to a tool. I'm recommending the NCCN. There may be another tool that you prefer, but I love that website. The third thing we talked about was that steroids need to be effective in a few days for those high-grade 3 and 4 toxicities. If they don't, you have to go on to more immunosuppressant. I didn't stress this part enough because this was a talk on side effects. But, you know, as much as I say there's side effects, you got to know that these are wonderful drugs. And most patients get just grade 1 and 2 side effects. And so most PD-1, PD-L1 inhibitors are very safe. We talked about how toxicity goes up depending on disease, the patient, the sequence, combinations, new agents, and pre-existing autoimmune disease. And then as part of informed consent, I told you to tell patients about risk to their brain, their heart, pancreas. I told you that we now can really talk about delayed immune-related adverse events. And I think in a couple of years we'll have more information about how common that is. For prescribers, always discuss the risks and benefits of these medicines in context with the disease. What's the goal of care, and the populations. A couple of years ago when I talked about this, the population was really centered on COVID because we didn't know what would happen during the pandemic. But patients who developed COVID and are on these medicines actually didn't do as poorly as I thought they could have. So we do have time to test knowledge. This is a really tough case. It's real, but I changed the age and such to hide the patient. She's 71, never a smoker, on treatment for hepatitis B. She has adenocarcinoma of the lung. She's got this KRAS mutation. Her PD-L1 is 10%. She's treated with carbopemetrexate and has new cancer in her celiac nodes and bones. So her oncologist stopped the carbopemetrexate and switched to pembrolizumab. And then after being on pembro for a while, she was then started on paclitaxel. So in the background for this poor lady, she has had several agents that could be toxic to her lungs. Paclitaxel can be toxic, pembrolizumab could be toxic. Pembro stopped, but it could be a delayed immune-related adverse event. She has Hep B. She comes in the hospital, she's hypoxic. And so what is her diagnosis with all this stuff in her lungs? Does she have immune checkpoint inhibitor pneumonitis? Does she have a chemotherapy-induced pneumonitis? Does she have COVID? Does she have an atypical bacterial infection? Or does she have a fungal infection? I found a case in the literature that was similar to hers, so I put the reference there. And what do you guys think she has? This is a totally unfair question, and people know me better actually know I write exams for part of my living, and so this would be a thrown out because there's more than one answer here. This patient had, she did not have SARS because we were able to check her respiratory panel, and she did not have COVID. She did not have bacterial infection, but she had a fungal infection, and she probably had immune checkpoint inhibitor pneumonitis delayed. She might have had Taxol pneumonitis. Those are treated the same way. So she's placed on steroids, and she had pneumocystis, pneumonia on top of that. So there's a few cases out there with pneumocystis occurring in these patients. Her treatment was high flow oxygen, covered her for atypical pneumonia with ceftriaxone and azithromycin. So as you're answering these questions, all of these treatments were given at once. So a very hard case. So this lecture is actually studded with things that you could read afterwards. I encourage you to do your own studying so you feel really, really comfortable handling the side effects for your patients. We have time now to go over the questions that are in the chat. And in pandemic fashion, Tim and I are masking up. So here we go.
All right. Well, this is wonderful. Thank you so much.
Thank you.
Let me see. Let's see if I can get the clicker there. We'll go ahead and advance to the next slide. And so that's our Q&A one, and I actually need to moderate this, so bear with me for just a moment. And I will. All right. So we are ready to take questions. So if anyone wants to submit a question, please go ahead. What's next? What's on the horizon? If we're fortunate enough to have you back in 2 years, what do you think you might be? Obviously, no crystal ball, but what do you think you might be talking about?
If we do a side effect talk again, we'll continue to expand on that. We just touched a little bit today on the LAG-3 inhibitors, but that's part of the checkpoint.
Right.
I think what really needs to be done next is to just fine-tune this and figure out who needs these treatments and who doesn't. In melanoma, we learned years ago that we don't need to check a PD-L1 because they have such a inflammatory milieu that they get better. But a lot of these medicines are being used in the adjuvant setting, and none of us like to see side effects if the patients don't really need the drug.
Right.
So that'll be nice to know who really needs them and who doesn't.
Gotcha. Thank you. Well, we have a couple of minutes, so we would love to hear from you. We would love to hear your questions. Let me just make absolutely sure that is up there. So you should be able to go ahead and submit your questions, and we will look forward to taking those.
Has anybody out there prescribed mycophenolate or other immunosuppression agents for patients of theirs on immune checkpoint inhibitors, or do you feel a little bit wary about it?
All right.
See if anybody can answer me on that.
And we do have one that just came up. Is there a way to include primary care as a resource when patients experience symptoms caused by their treatment?
So I think what they're asking is the primary care doctor included. Oh yeah, we've worked so much with so many PCPs, especially when we cause the poor patient to have type 1 diabetes. Because that is just such a wheelhouse for primary care physicians. And then sometimes I'm kind of surprised who takes over. I recently had a patient develop pneumonitis, and she went to Wake Med, and the pulmonary physician there is doing all of the steroid treatment for the patient. So it's funny who's going to take the baton, but someone needs to take the baton and say, I'm the one doing it, I'm the one who's going to follow the steroid dose and help the patient.
All right, thank you. And again, we do have just another minute or so we would love to hear any last questions that you would like to share with Dr. Collichio. In terms of that involving the primary care doctors, I know that's something we've heard about sometimes in previous lectures, people talking about the difficulty of bridging that gap between the oncologists here and the primary care physicians.
I love the way EPIC is now aligned better with the PCP. If you get your patient out, you can click and all the notes will go right to the PCP. But everybody should call the primary care doctor if there's a problem.
Yeah.
Yesterday we had a patient whose heart rate was literally 33. And we contacted the primary care doctor right away because a bradycardia like that would not be a side effect of his treatment. But the primary care doctor was incredibly helpful guiding us through that. So yeah, they need to be part of it.
All right. Well, I'm going to keep this where I can see it in case we get any last questions in the next minute or two. And then I'm going to go ahead and say our thank yous. We want to thank the people in North Carolina, the University Cancer Research Fund, and the UNC Lineberger Comprehensive Cancer Center, and all the wonderful work that's done there. We want to thank our team, Venny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh. All of them put a lot of work into each one of these lectures, from inception to publication to a year or two later when we close out the final enduring material. So lots of work there.